Thanks, Viraj, again. So we'll have this panel on advanced gastroesophageal cancer. So we have all our panelists in here. Amit is there, Chintan, Dr. Mansi, Nilesh, Aditya, and of course, Viraj, who is the organizer for today. So we will, it's now 8:10. You can pick up your plates, sit down, and then we can discuss, no problem. We'll try to finish well ahead of time. I've got 3 cases, but we'll only discuss till we have time. So this is a 67-year-old diabetic, dysphagia, abdominal and back pain since 4 months, 7 kg weight loss over the past 4 months, no other comorbidities. Examination was unremarkable. An upper GI endoscopy showed a lumen occluding growth, 30 centimeter, which is the lower 1/3. Scope could not be negotiated any further. A biopsy from that growth showed a poorly differentiated squamous cell carcinoma. His blood work was normal. So this is the PET CT scan of this gentleman. You see here that this is the lower 1/3 of the esophagus showing a growth, extensive lymph nodes down up to the kidneys, bulky lymphadenopathy, and almost a lumen occluding growth. You've got just a small slit. He could just swallow some liquids. Even that would regurgitate often. So this is where we are in terms of our patient. So this is advanced esophageal cancer, squamous cell carcinoma. So what is the next step that we should be taking? Let me start by asking Dr. Mansi, the lady first. Dr. Mansi? Okay, Amit, what should we do next?
So how bad was the dysphagia?
It is just a trickle of water that goes down, Amit. Bad.
So I don't go for palliative RT in such high volume disease.
Right.
I think, I don't know why biomarker testing, but whatever hurting you must be thinking, wasn't it squamous cell carcinoma?
It is squamous, Amit, correct.
Okay, fine. So I quite often start with the systemic therapy, but there is always an option of stenting. It is a subjective sensation. Quite often patients do very well after systemic therapy.
Right.
And they start eating very well. But I think if the stenosis is perceived to be too tight and the patient is very malnourished, then I think stenting is a pretty good option to begin with.
Okay, so if possible, stenting would be a good option, but you would prefer to do systemic therapy. Nilesh?
So I think relief of the dysphagia is paramount, not just from the patient's quality of life, but also from tolerance of systemic therapy.
Absolutely.
So it's like you said, it's relative. If I feel the patient is significantly obstructed, either an NJT or a stent preferably goes in. That is the first priority. The next would be considering some biomarker testing, and that would vary between doing the PDL1 by CPS, the MSI testing, the HER2. I do understand this is squamous, but there are patients who also have these mutations in squamous. So I definitely like to do that. And then I will decide on my systemic therapy, whether I'll go for taxane-based, 5-FU-based, or an immunochemo combination.
Okay, so you're saying that you would prefer stenting or an NG tube to be inserted and then start systemic therapy. You would also not prefer to do radiotherapy. Viraj?
So I agree, dysphagia has to be relieved.
Right.
We do stenting, and then I agree CPS score. I don't do HER2 MMR for squamous at all. And then if CPS is more, I do IO chemo, otherwise chemo alone.
Okay, CPS score, IO chemo. Of course, Nilesh has also said MMR. That's something that we will also consider doing, across anatomic subsites. Chintan, any difference of opinion there, Chintan?
No, same. Stenting and
no,
then
you would agree.
biomarker.
Dr. Mansi, are you in?
Yes, sorry, I got disconnected.
That's
but
fine,
I agree. I agree with everybody. I would first palliate the symptoms and then start the palliative systemic therapy.
Excellent. So we will all palliate the system. Aditya, you will also agree?
No, absolutely.
Absolutely. Very good. But what we did was palliative radiotherapy. We did do 10 fractions of radiotherapy, fully well understanding. So we did talk to the gastro people. They said putting a stent in, negotiating it might be a little difficult. So after a lot of discussion, we decided to palliative radiotherapy. 10 fractions were done. This patient's block was sent for biomarker testing. And as Viraj rightly said, the only biomarker that we tested for, because it was a squamous cell carcinoma, was PDL1, and that too by CPS. So let me come back, Nilesh. What cutoff would you use in order to choose your patient for immune checkpoint inhibitor? Should all comers be given immune checkpoint inhibitor as the FDA says, or you would say any positivity is fine, or more than 10%? What is it that you would choose in order to offer an immune checkpoint inhibitor?
So since we are speaking about
Squamous.
esophagus, whether squamous or adenocarcinoma,
Okay.
The treatment we are speaking about is mainly pembrolizumab with chemotherapy.
Okay.
And as per the pivotal trial, that is the Keynote 590, the CPS was done. And while patients were evaluated at more than 1, less than 1, and more than 10, and the quantum of benefit was seen in all subgroups. So it was for all comers, also all comers seemed to benefit. But definitely the quantum of response was much better. The hazard ratio was much lower in those patients who had a CPS of 10. Now the big question is CPS of 5 in some places, CPS 10 with nivolumab at CPS 5. So it's a little difficult, but it's reassuring that in this, at least in esophagus with pembrolizumab, irrespective of your CPS score, patients seem to benefit.
Okay. So Amit, would you also agree with Nilesh that you shouldn't worry too much about doing the CPS score? If your patient can afford, just throw it at your patient, come what may.
Yeah, so you have answered the question. The
Excellent.
affordability becomes the most common practice.
Okay, so if affordability is there, then you would go ahead and give it. So is the clinical benefit, is the benefit in patients who have a negative PD-L1 or a PD-L1 that's less than 10, considering, 590 study, is that clinically significant? Because if you look at the forest plot, you will see that the benefit is actually driven by patients who have
more than
CPS
5.
of more than 10, in 590. The 5 story is a little, it's a different study. As you rightly said, Nilesh, it's confusing. One is just positivity, the other is 5, the other is 10. So Amit, would you think that, let's say this patient ended up being negative. Let's take 590 study for the moment to discuss that. The clinical benefit would probably be nearly zero. I say nearly zero, not zero for that matter. So do you think that would be clinically significant?
Yeah, so there are multiple ways of looking at it. You
Okay.
can read the literature in multiple ways. I think my point boils down to the way we tell the patient the potential benefit gets modified automatically when we look at the CPS score. Do I do the CPS score? I do the CPS score.
Right.
If I have somebody who has a CPS score of 15 or 20, not very often, but if they have score 15 to 20, my enthusiasm for suggesting immunotherapy automatically goes high.
Right.
We can start bargaining of the quantum of benefit. So yes, I factor in the CPS because I factor in the fact that what is the probability of benefit. But if for somebody, exceptional cases, even if the CPS score is 0, 1, 2, 3, 4, 5, and the money is not an issue,
right.
People are far and few, honestly speaking.
Absolutely.
Then, if they can, then it's fine. But you're right in your question, there is a decremental benefit with decremental values of CPS, and possibly around 0, the benefit may be close to 0.
Excellent. So I think all of us believe in the fact that there is some predictive value to CPS, but all of us also, understand that not having a positivity does not mean that there's absolutely no benefit. There might be a small benefit, but beauty lies in the eyes of the beholder. So if that benefit is big for that patient and it's clinically significant in that context, I think we should go ahead and do it. So that's fine, because that's how the FDA approval is. Viraj, Nevo or Pembro, Viraj?
So I do Nevo with CPS positivity.
Any positivity?
I don't do CPS 0. I will not do IO first line.
Okay.
Maybe perhaps subsequent lines. My choice is Nevo.
Why did you choose Nevo, Viraj?
So first of all, a lot of experience with Nevo because it has PAP in many, at least GI subsets. So I'm very comfortable with Nevo. And the 648, I think so it's there for squamous. I think so I'm very convinced with that data.
Okay. So you're thinking the magnitude of benefit that you're seeing in 648 is better. 648 is a much more, homogeneous study because they took in only squamous patients. In the 590, there were squamous and, adenocarcinomas. In fact, there were more adenocarcinomas than squamous carcinomas, if I'm not mistaken. And the primary endpoint was more than 10. You have a point there, Viraj. If you look at the data cross comparison with all the caveats in terms of the inclusion criteria, it seems to be that Nevo is a little better. Aditya, Nevo or Pembro, Aditya?
Given this is a squamous cell and it is still esophagus, at least in a upper esophagus, mid esophagus to certain extent may behave a little bit more like head and neck cancers. And if you're talking about first line therapy, CPS 10 and above, probably I would err on giving for pembrolizumab.
Okay.
So Pembro, but given that the biology is more, I'm trying to explore a little bit more of an experience from head and neck as well there.
Okay, so you're trying to extrapolate from head and neck cancers and saying pembro might be better. In fact, 648 study showed that even if you have more than 1%, the magnitude of benefit is huge. There's nearly a doubling of the overall survival from somewhere around 8 or 9 months to around 15 months with a hazard ratio of 0.54. So, Viraj's point seems to be valid that Nevo cross-comparing seems to be a better one. Anybody for AP Nevo, Dr. Mansi?
No, sir. EP Nevo, I mean, we are still awaiting that arm of study, the results of that arm. So I'm not really comfortable with that. About your previous question,
Yeah.
whether I would offer IO in non-expressors of PDL1, well, it would depend on the fitness of the patient, the age of the patient, the chemotherapy arm that they would be eligible
We'll
for.
come to the chemotherapy. We'll come to the chemotherapy in a moment. That's a bigger controversy, I suppose.
Yes. No double IO for me.
Okay.
I would also go with Nevo because of the assistance and the comfort of using it. But Pembro, if it is PDL1 more than 10%, I wouldn't really counsel them against Pembro more than 10%. If it is between 1 to 10%, I would definitely push for Nevo.
Okay, so you're using the CPS score to decide. So I think all of us have our own ways of, navigating through this, mess of a data, I would say, because of the heterogeneity in terms of inclusion of patients, the CPS cutoffs that people have used. In fact, we haven't discussed about what antibody to use. Let's not get into that. That will be a greater mess.
There is a question, Senthil, on this.
Yeah. Amit.
How do you use CPS for nivolumab? I mean,
so if you look at the 648, Amit, even if you had any positivity, the benefit was quite significant. And as always, the higher the benefit, the higher the CPS, the better.
If you want to use Nevo, are your labs equipped to give CPS?
Yes, CPS.
I think so. The question that he's asking is they used to 28.8.
28.8
was in 577. Yeah.
So no,
is the lab giving CPS?
No, we don't have it, but we have data
Yes.
that 28.8 and 22C3 both being manufactured by DACO. They are concordant.
Oh, okay. You're asking which antibody you would use to do CPS if you wanted to do Nevo. Is that right, Amit?
Yes.
Yeah. So you see, with the 22C3, our labs have learned how to do CPS scoring. But has our lab learned how the CPS scoring is done with Nevo?
That's a good question, Amit. I think I really don't know the answer, but I'm assuming what Viraj said is probably the practical way of looking at it. Because just for the sake of
disconcordance, Viraj talking about the lung,
he's saying he says it's concordant. I don't know
data set.
Viraj, I don't know whether there is data in GI cancers. I think we are extrapolating from blueprint in lung, isn't it?
Correct, sir.
Correct. So I think you have to be a little shaky there. I think Amit has got a very good point there.
So then the concordance is not in CPS, the concordance is in TPS.
TPS, that's correct.
So how do you know that the concordance of TPS and lung will turn out to be concordance for?
Absolutely. You can't assume that, Amit. You made a very important point.
You need to read the article and you need to sit down, because I've yet not started anybody on IO. I'll be honest, frontline, Nevo or pembrolizumab, Pembro. So, but I need to sit down with my pathologist. Are you going to do the CPS the way we want it?
I think that's the ideal way would be to use that particular antibody for that drug. I think that's the best way to do it. But, many times this extrapolation kind of happens, and that's something that we cannot avoid in clinical practice. But the good thing is, as we started by saying, all comers benefit, patients who have CPS benefit higher. So you would not be absolutely wrong. But the most appropriate way of doing it would be to choose the right antibody. Amit, you made a very appropriate and important clinically relevant point there. Okay, so we will leave our immune checkpoint inhibitors and then get on to the chemotherapy. Chintan, what would be your chemotherapy if you were not using an immune checkpoint inhibitor?
So it will be most likely to be a FOLFOX-based regime. Most of the trials have tried 5FU with cisplatin, especially in the squamous subset, because initially it was thought as the spectrum of the head and neck cancer. but Folfox is giving equally good results, and there are trials which shows that oxaliplatin-based regime may be slightly more effective and less toxic.
So routinely for squamous cell carcinoma of the esophagus, you use Folfox. Am I right
Yes.
understanding that?
Yes.
Okay, fine. Viraj, what would be your choice of chemotherapy if you are not using an immune checkpoint inhibitor?
Taxane based.
Taxane based. Paclitaxel is what you would be using?
I use Dosis, but
Dosis. Okay,
but less
okay.
Paclitaxel.
Fine. So a taxane plus a platinum. Nilesh?
So either a taxane and a platinum combo or a 5-FU cisplatin, depending on other issues also.
Okay, so but 5-FU cisplatin is a little cumbersome, isn't it, Nilesh? So
it is, but sometimes cost is an issue. That's why. Although having said that, nowadays the taxanes are hardly expensive. So, but there are some situations where I have used it. That's why I mentioned it. But my choice also would be docetaxel or paclitaxel with carboplatin or cisplatin.
okay, so a taxane plus platinum. Dr. Mansi?
Yes, sir. I would also go with a taxane plus platinum. In fact, for cost, in the hospital, 5-FU turns out to be more expensive because of the hospitalization cost, not because of the drug cost. So it is a compromise. But yeah, if patients can afford and tolerate 5-FU cis, I'm open to 5-FU cis as well.
Okay, excellent. Aditya?
Mid and lower esophagus, we do Folfox.
You do Folfox. Amit?
Same opinion, no difference.
Okay, so suppose you were using an immune checkpoint inhibitor. In your case, let's say it's Pembro, Amit. So what would your choice of chemotherapy then be?
Then the question will pop up. As I said,
yes.
use immunotherapy in any of my.
Okay, so let's say tomorrow morning you're getting a patient who's got a deep pocket.
Therefore, the Pacli-Carbo or a Pacli-Platinum, whichever way you say, would make sense because it'll be easier to do with pembrolizumab. But then the question comes, if you're going to do with nivolumab, then possibly Folfox would be a better choice. I mean, if you're talking about 2 weekly versus 3 weekly issue, is that the point in your mind?
Correct. So now, now Amit, they're kind of doing all. So now with the per kg body weight dosing coming in everywhere, you can do it 2 weekly, you can do it 3 weekly, you can do it 4 weekly. So all sorts of permutations and combinations. Just in the upper GI trials, if you look at it, they've used Capox with nivolumab in some studies. They've used 2 weekly ones, 3 weekly ones. But the point I'm trying to make is that Pacli-Carbo, except in the Chinese study, the ESCOT study, where they've used a PD-L1 inhibitor called camarolizumab, there are no other studies where they have used Pacli-Carbo with either Nevo or Pembro. So would that be a deterrent for you to do Pacli-Carbo along with this drug? Because if you're looking at the label, then Pacli-Carbo is not the combination to go to. So would that be a worry for you, Amit, or a concern?
So it'll be easy for me because Folfox remains my favorite regimen.
Okay, Folfox. So when you want to use an immune checkpoint inhibitor, it'll be Folfox. Otherwise, either of this is fine. Viraj?
No, I'm not sure Folfox responses in squamous. Honestly, I have tried in multiple patients. I always find it fall behind than taxanes. I have a series of around 6 patients now, which I have used taxane platinum and IO.
Okay.
2 of them are in CR. Both of them had a PD-L1 CPS, I should say, more than one of them 40, one of them 50.
Very good.
I don't find any difficulties in combining them with taxane.
At least in theory, you would not have a problem because when you calculate the per kg body weight, you can certainly use it once in 3 weeks. So you've used Dosi, Platinum, and nivolumab. Is that correct?
Yes, Dosis, Nevo.
Dosis and Nevo. Anybody has got a difference of opinion on that to what Viraj is saying, that you should not be using a taxane platinum combination with an immune checkpoint inhibitor because there is no data? Is there anybody? Nilesh, would you agree?
So as per the 590, it is Cisplat 5-FU and Pembro.
Correct.
But I think given our experience from TNBC, whatever little we have, and from other studies also, I don't see any harm in combining a taxane platinum with this.
Very good. So I think all of us agree that it's okay. You can do all sorts of permutations and combinations with a chemo backbone that you are comfortable with, and the immune checkpoint inhibitor data that you are convinced with, and comfortable using, both in terms of toxicity and the cost. So just to summarize this little bit of a messy discussion that we have had with so many opinions being thrown in, we'd all like to do the CPS because we understand and agree that it is predictive, but we are okay to offer it even if the PD-L1 is negative. There was some difference of opinion, but that's okay because the FDA label says you can go ahead and do it. Most seem to be in favor of a taxane platinum, if an immune checkpoint inhibitor is not being used, but if an immune checkpoint inhibitor is used, most seem to be in favor of using FOLFOX, because that's what has been more commonly used in many of these studies. There is a problem as far as CPS is being done with the antibodies, which are typically not used with that immune checkpoint inhibitor, at least in the clinical trial. So one should be a little careful when you're extrapolating data from there. So if your patient can afford and there is no contraindication, throwing in an immune checkpoint inhibitor with whichever chemotherapy you're comfortable with seems to be the way to go. So this is the 2021 NCCN guideline. As I've marked at the bottom of the slide, the FDA approval of Nevo and Pembro is irrespective of PD-L1 status. So you can go ahead and use it, but we have around reservations on that. Nevo plus chemo based on Checkmate 648 will be, I think, added to this list for anybody who has a PD-L1 that's more than 1 CPS. So that's what I think will be the new addition based on the 648. Doing IO plus IO is not giving you any additional advantage over the chemo plus Nevo as in terms of overall survival. So IO plus IO, like in most other anatomic subset, kind of gets left over somewhere. You want to have a very fit patient who doesn't have too much of tumor load, who's ready to accept those side effects, and that's probably the patient who will go in for IO plus IO, a very niche subset, I would say. So that is the kind of option that you will have for a patient with squamous cell carcinoma advanced in the first line. Okay. So,
quick question.
Yes, Viraj.
FOLFOX for squamous cell carcinoma, which trial are we talking about?
FOLFOX for squamous cell carcinoma. I think the 648 also had FOLFOX, isn't it, Viraj?
Right.
Nevo. Viraj,
it had platinum plus cisplatin plus 5FU.
Did the 648 have cisplatin plus 5FU?
Cisplatin plus 5.
I'm not
Cis 5FU.
Okay, fine. So,
no, my point is oxaliplatin has never succeeded in squamous histologies in any anatomies. That was my concern.
Okay, so never mind. So I think we are kind of reasonably convinced that some comfortable chemotherapy for the patient and the doctor. But Viraj, it is, I think, one of the accepted combinations for treatment of squamous cell carcinoma of esophagus.
In fact, in this NCCN, there is nothing like platinum and taxane.
Exactly. So that's why I raised that point. There is none, except the Chinese trial. Yeah. There is no other study which has used paclitaxel as the chemotherapy backbone, and that's a totally different immune checkpoint inhibitor. So that's the reason why I asked that question. Yeah.
And in SQUAME, they have given the references for, it's a combination of adeno and squamous cell carcinoma, but most of the squamous cell carcinomas mentioned 5FU platinum and pembrolizumab, and 5FU oxaliplatin and pembrolizumab for adenocarcinoma squamous cell. So the approval is not.
That's what I'm saying. This is for squamous, ox is for adeno.
There is no regimen here of taxane and platinum.
No, I agree. I'm just talking about cis and ox.
I agree, but if you look at the second last line, forget about the immunotherapy.
This one.
5FU and oxaliplatin
or squamous cell carcinoma. Yes, so that's why I said, FOLFOX is there in some of these studies for squamous cell carcinoma. Yes, absolutely agreed, Viraj. You may have your point to make, saying oxaliplatin is not a great platinum for patients with squamous cell carcinomas, but Amit is also right that the recommendation here clearly mentions that as one of the options. But as also rightly pointed out, and that's the point I was trying to make earlier, paclitaxel is typically not something that is being used in these trials with immune checkpoint inhibitors, irrespective of squamous or adeno there, except the Chinese ESCOT study, as I said. Okay, so we will move on to the next one. Okay, so our patient had a CPS of 15. This is 22C3. This is not 28-8. He was started on FOLFOX first, and then 12 days after the second cycle, wherein we added Nevo to the FOLFOX. He came in with breathlessness of 2 days, low-grade temperature, and this is the CT scan that showed. So this guy this was during the COVID peak, the second peak, and 3 times COVID test was done, and it was negative. So what shall we do, Nilesh?
So assuming that we have ruled out other etiologies, it is highly possible that this is a immune-related pneumonitis that the patient is having.
Okay.
And I would accordingly, firstly, and from what you said, he's symptomatic, he's breathless. I'm assuming his saturation is low.
Saturation was some 94, 93 room air.
So this is something like a grade 2 or grade 3, depending on as per the CT scan. So
Okay.
I would keep that as a strong possibility and consider treatment with steroids depending on his clinical condition.
Okay, Dr. Mansi, you agree with Nilesh?
Yes, sir, I do agree with him because if COVID has been really ruled out thrice.
Yeah, 3
and-
times ruled out.
Yes. So the next thing which we would want to rule out is that, yeah, ideally you should be doing a biopsy of the lung lesion, but then I think we would treat him with a trial of steroids and then see how he responds.
Okay, Amit, you would also do the same?
Did you do bronchoscopic COVID RT-PCR?
Bronchoscopic COVID RT-PCR, no, Amit, we haven't done
If
that.
you give me this CT scan image at this point of time, these days I can only think of COVID. You must be wrong.
Okay. You are so confident that I'm wrong.
I'll give you. I mean, it is out of the track thing, but we recently had a case where we had to prove a bronchoscopy.
Okay.
PCR, but that's besides the point. The rest of the thing which I said, I completely agree with.
Okay, so it's just that my concern was, Viraj, this is just 12 days after the nivolumab. So do you get immune-related adverse reactions
So
12 days
exactly
after?
my point.
That was your point. Okay.
That I would do BAL and rule out any other things that.
Okay, you would do BAL and rule out any other thing. So it is a little unusual. I wouldn't say little unusual, almost very, very rare to have an immune-related side effects within 12 days of the first cycle. Usually they start coming in the 3rd or 4th week. It's not that it's impossible and you will never get one like this, but it's generally not what you would think as the first possibility. Okay, so this guy declined a bronchoscopy. COVID was tested thrice and he was negative, but still the pulmonologist said you have to treat it like COVID. So he had steroid because he was hypoxic. And then that was the time when remdesivir was very widely used. He didn't have any antibody cocktail. So we finally didn't have a diagnosis on this, but he went on a tapering dose of steroid and then became all right. We repeated a CT scan after 3 weeks of steroid. I mean, it was a little better, but not, I was not confident enough to re-challenge him, though, all scientific data would say that it is less likely to be Nevo. So would anybody re-challenge Nevo, Nilesh?
No, considering that the response has not been very good and he still has significant opacities in the lungs, I would not be keen to.
You would not be keen to re-challenge.
No.
Aditya, would you re-challenge Nevo?
With the CT scan looking like this, maybe not. If CT scan was looking a little better, maybe. But see, we know that CT scan improvement takes a little longer than the clinical improvement. And if it's a grade 2 pneumonitis, we can re-challenge. But if the scan is looking like this, I am not that brave.
Okay, Amit, are you braver than me? Amit, are you around?
Knowing.
Yeah, go ahead, Amit. No, I didn't hear you.
My internet is breaking.
Okay.
And then what I'm saying is, because you are asking questions, there must be a catch point, and that must be that you must have re-challenged the patient. I would not dare.
Look at the kind of reputation I have built up. even when I'm truthful, you don't want to accept it. So I'm now going to say I re-challenge. Actually, I didn't re-challenge. I didn't re-challenge this patient because I didn't have the guts to re-challenge. As simple as that. Okay, so we didn't reach. Yeah.
So I must say, among all the different immune-related side effects, the one place where I'm very hesitant in re-challenging it with pneumonitis is a patient who's got bad pneumonitis. With colitis, rash, it's probably okay to do it. I've had a bad experience. I lost 2 patients. So I've been a little hesitant.
So we didn't re-challenge this patient. So this patient continued on just FOLFOX. So he had antibiotics, steroids, things that we do when we don't know what's actually happening. We threw everything at him, and fortunately, by God's grace, he got better. We stopped Nevo, so he had 2 more cycles of FOLFOX. So he had 5 cycles. The dysphagia was better because of probably the palliative radiotherapy. The abdominal and back pain continued to be there, though a little better because of all the steroids, maybe. He had a PET CT after the 5th cycle. He had new neck nodes. Remember, this is level 2, 3, not the lower neck, upper neck. A few abdominal lymph nodes are increased in size with no increase in the SUV, while few nodes were stable and decrease in SUV. So kind of a heterogeneous response that this guy had. So, it was level 2 and 3. So we decided to do a biopsy. The biopsy showed a necrotizing granuloma in the neck. So he was started on anti-tuberculous treatment, though we didn't see acid-fast bacilli or anything. They did all those serology and stuff like that, and then finally decided to go ahead with ATT, right? So what would you do now, Viraj? Change of systemic therapy, or should we do an abdominal node biopsy because there's some necrotizing granuloma in the neck?
No, I would continue, sir. Take it as stable disease and consider abdominal node as TB and just go ahead few more cycles.
So you would consider the abdominal lymph node also as TB and continue systemic therapy. I mean, continue the FOLFOX.
Give more 2 more months and rescan.
And then reassess. Okay, Dr. Mansi.
So actually, initially, before giving up on Nevo itself, I would try to get a biopsy from the lung before giving up on Nevo.
Okay.
And I would also be curious now, what is the condition of the lung with the node?
The lung was a little better, Dr. Mansi. So I wouldn't say, it was
even after 3 cycles of FOLFOX.
Yes, so that was another 6 weeks. It was better, but I wouldn't say, dramatically better. That it wasn't normal.
Okay. So yeah, so maybe it's stable disease, and see the response to ATT. Generally, it starts coming by 4 to 6 weeks.
Okay.
So maybe repeat a scan with the same treatment after 6 weeks or so.
Amit, abdominal lymph node biopsy? No.
Did you do an abdominal lymph node biopsy? Right?
I did. So if I'm asking you 3 times, you know what I did.
Yeah, I mean, ideally speaking, the abdominal node biopsy should have been done right in the beginning also, actually.
Okay, right at the beginning.
But I would have done the biopsy. I think Mansi's thought process about lung biopsy really makes sense. What if it was something else? It really makes sense. Although doing a lung biopsy at that point of time is really, really difficult. But I think I would at least do an abdominal node biopsy and see what's going on there.
But the lung biopsy, so we did an abdominal lymph node biopsy, a EUS guided, EUS biopsy, and the biopsy came as squamous cell carcinoma. So that's a different story. But, Amit and Dr. Mansi, suppose that we do a biopsy from the lung and that just shows some, pneumonitis that's burning out, how would that help you to decide whether you want to use Nevo or you're thinking of some other? Yeah, correct.
That one.
So
if there was a granulomatous change in there.
Yes.
Okay, you're talking about. I think we did not. So the fact that he had some, I think he had Magnex or something like that with clarithromycin. You can always say clarithromycin has some anti-tuberculosis activity. But for that, it was plenty of steroids and stuff like that. So, I'm not sure.
Retrospectively, you're learning that. Now you have a necrotizing granuloma necessitating ATT. What if the lung also had the same thing? It's retrospectively.
Fine. Anyway, we have started him on ATT. So again.
There's a point.
Okay, fine.
No, so in fact, I didn't think of it retrospectively. I was all along thinking.
All along, you wanted a lung biopsy.
I even said it earlier that ideally I would still do a biopsy before starting steroids, especially in the COVID scenario, because steroids would respond in both the situations. Give a response. And secondly, someone who can afford an immunotherapy, I would rather push for a biopsy if your interventional radiologist and pulmonologist are good. It would just be like 15,000-20,000 more and be sure.
The cost is not the issue, Dr. Mans. So the question is, somebody was on oxygen and unwell, and then to push them to get a lung biopsy is not easy. It's not impossible, but it's not easy. Right. It's not, Amit made that point earlier. It's very difficult to get any intervention done on somebody who's sick, with oxygen and so on and so forth. Anyway, so we did an abdominal node biopsy. We did not do a lung biopsy. The abdominal node biopsy showed squamous cell carcinoma. So what do we change to? So we are out of FOLFOX now. Viraj.
The rest of the disease looks stable, sir. Is it right?
There isn't much disease otherwise. We have radiated the esophagus.
The primary.
Yes, and then some lymph nodes have increased in size. Some lymph nodes have a mild decrease there. So it's kind of heterogeneous, as I said. So you're saying you will still continue the FOLFOX?
I have done that. I would say in a heterogeneous.
Okay, fine. So you would continue the FOLFOX.
We don't have a magical drug after taxane.
Absolutely. So Nilesh, change of drug or same Nilesh?
So if the patient is symptomatically improved, I feel I'd probably continue the same
He was just
treatment.
the same. He was just the same.
I am tempted to change the treatment to a second line.
Okay, what would you choose of that list, Nilesh?
So we have options between a taxane or irinotecan or a taxane with ramucirumab. My use with ramucirumab is not. Oh, this is
Squamous, Nilesh.
taxane and carboplatin. Paclitaxel is something I would use.
Okay, fine. So we ended up. So anybody, Chintan, you've been quite.
Sir, I would be continuing the same for two more months and repeating a scan and seeing whether the patient is not symptomatically the same, so would not hurry to change.
Okay, you would not be in any hurry to change because you don't have a magical second line drug. Aditya?
I agree. Very little clinical changes. The patient has also probably not received sufficient chemo because there was break because he was sick and only 5 cycles, only 3 months, maybe 2 more months of the same and see where we go.
Okay, 2 more months. Amit, you would also agree? Stick on to FOLFOX?
You're the best person to answer because you're seeing the patient. So I would answer the question that we don't chase the scans.
Okay.
We don't treat the scan.
Absolutely.
Everybody is trying to say the same thing. So the patient and the treating physician will get a hang of it. Are you dealing with a clearly progressive or not? So if you feel that it's more or less stable, and I think the last gentleman raised a very relevant point, one may not have been able to treat appropriately also. So it's a classical standard situation in the clinic, and you get a feel of it. Are you really progressing or not progressing? If you're not, you continue. If there is an obvious symptomatic or a scan, but not just the scan, then you change. But you want to know about the change. That's what your point is. I would go for paclitaxel.
Okay, if you want to change, you go for paclitaxel. So we didn't change. We just continued the FOLFOX for a couple of more cycles. And of course, he progressed after that. And then he went on to have weekly paclitaxel for a few weeks. And you won't believe that the lung flared up again. Right. So we actually don't know. I mean, he was so sick the next time that we couldn't do we thought of a biopsy, but we didn't do a biopsy. Anybody for an NGS?
No.
Okay, Nilesh?
Not very convinced for squamous. Yeah. Having said that, was any test done initially? Like
no.
MSI definitely I'd like.
MSI was done. MMR was done rather.
Having said that, we are not going to re-challenge him with immuno.
Absolutely.
Yeah.
Okay, so that's what happened to this patient. So we did continue on FOLFOX for 3 more cycles, and then we found that the abdominal lymph nodes had increased further. And since it was already biopsied, it was squamous. So we changed to weekly paclitaxel. And as I said, things worsened because his lung worsened again. And then we decided to lay off. He's just on symptomatic supportive care only. Reasonably okay, I should say. Viraj, do we have some time for a short case?
Correct, sir. Yes.
Okay.
And I have a question for all of you.
Yeah, please ask the question.
So I have a 70-year-old lady, MSI high G junction. She had peri-op flot, underwent operation 1 year ago, and then had an abdominal recurrence. We treated her with single agent Nevo, 4 cycles, complete response. But then she had grade 4 colitis, and I'm still battling that colitis for last 4 months, with steroids and whatnot you have. And I rescanned her last week. She's still in CR. Do we consider, since you brought up the toxicity question, I wanted to ask, would we ever consider re-challenging with any other IO, or just wait for the inevitable?
I would not personally re-challenge with any other IO, Viraj, and all the more because the patient is in complete remission and the colitis is still going on, and we don't know how long it will go on. So that's my opinion. Amit, you have a different opinion?
Did we try infliximab?
So there is one, but something like that, oral tablet, the gastroenterologist has started, after which she's done better. She's doing well on MMF and that oral pill.
Okay.
Now it has settled down.
Mycophenolate works very well.
Mycophenolate and
so no re-challenge of IO is bad. So you go ahead.
No, sir.
Amit can't hear you, Amit. Yeah, go ahead, Amit.
So I would not re-challenge with IO at this point of time. I might consider at very late when possibly this remains the only option. I have never done so with bad colitis, bad pneumonitis, not done so. But I think I would only do when that's the only option.
Agreed. So in short, wouldn't re-challenge. Anybody would re-challenge or dare to re-challenge, should I say?
I don't think so. She's got such a
Okay.
long-standing problem. I don't think so.
Okay, so we can just sit tight. So Viraj, that's the answer.
If she has disease coming back, then
And if the colitis is an absolutely in remission of all drugs for the colitis for at least 3 months, then I would
Then-
consider.
okay.
And if you didn't have any other option, so all the
Yeah,
caveats.
so as a last option or when
Yes.
you stock, I think you will take chances
Yes.
after
So,
discussing with the patient, obviously.
yeah, whenever you're desperate, you do things like that. And obviously, at some point in time, all of us are with our patients with advanced disease. Okay, quick. We've got 5 minutes. 67-year-old lady, no comorbidities. This is a cancer of the stomach. So you see that thickening, uniform thickening that you're seeing there. So on the scan, there were stomach, lymph nodes, peritoneal nodules, and some ascites, all that you're seeing on the scan. This is adenocarcinoma. The HER2 was 3+. After paracentesis, abdominal paracentesis, the performance status improved to 1. PD-L1 CPS with 263 was done for this lady. This was not our patient. This was somebody else. I don't know how it was done. MMR was proficient. Anyway, the point is this is HER2 positive. So what would you generally do, Nilesh? Would you do just trastuzumab or a combination of trastuzumab and pembrolizumab, the data that is there now?
So I didn't get the CPS. What is the CPS?
CPS, it was the report that I saw was 263, CPS was 25.
So, okay. So no experience, but trastuzumab with pembro and chemo is one option.
Okay.
Otherwise Folfox with trastuzumab and reserve pembro for a second line.
All right. Dr. Mansi.
Depending on how willing is the patient to take a chance, I would offer the Keynote 811 regimen
Okay.
with pembro, with trastu, with but
Pembrolizumab.
otherwise chemo with Folfox, Capox works fine.
Very
If
good.
they are not very educated and keen to take the risk or accept an off-label combination.
I think it's FDA. There's an accelerated approval, Dr. Mansi.
Approved.
I think
Approved.
yeah,
Yeah.
it is approved. Okay. Never mind. Okay, so you will give it if your patient agrees to it. So that's the point. Aditya.
Don't have experience. I'm not very keen on using things which I am personally not comfortable with.
Okay.
Agree with Dr. Nilesh, keep trastuzumab for first line and keep pembro for second line.
Amit and Viraj, what would be your choice? Patient can afford, no contraindication.
So, in
811.
fact, the point that you have shown is the reason I would use it, because I not used this major combination so far, but you're trying to say overall response rate, but in this patient, actually, I want overall response. He has ascites, he
Okay.
looks like a single cut large volume disease. I want
Absolutely.
this patient to respond. So what do I want? I want
Absolutely.
a 52% response or a
74% response.
I want 74% response.
Absolutely.
So-
Very good. Excellent.
So for this patient, if there's a reason, then I think this patient has a reason. For if the patient progresses on Herceptin or trastuzumab of any trade name, he or she may never get a chance to do anything. So if I believe in it, if the response rate has been approximately 50% more, I would use it.
Absolutely. Very good. So we would use it. Viraj, you would also use it in this
Yes.
patient?
811. Yes, sir.
811. Excellent. So we will use 811. There's no problem. So one of the concerns, agreed that for this patient where you need a lot of response, 74% certainly is much higher than 52. But independent of that, is this a concern that the median duration of response was not very different for the two, while you would generally expect pembro to improve your median duration of response? Is that a concern? That's not a concern.
It's a very short follow-up, sir. We only have, I think, 200 patients enrolled out of 800 planned enrollment. It's a very, very interim analysis. I think the phase 2 data, which led 811, showed a durable response with pembro.
Okay, so you're saying at least at this point in time, this is not a concern. Is that right, Viraj?
Yes,
One
sir.
would want to wait. One would want to wait for the data to mature.
It is not
Right.
mature.
for a final answer to come. But whatever we have so far is applicable for this patient.
Absolutely.
Somebody else, you may actually argue that one should wait for a mature
longer follow-up to get, because this is a, response rate is actually a secondary endpoint of this study. It's not the primary endpoint. And very interestingly, based on a secondary endpoint, the FDA has actually given an accelerated approval. So that's the way it is. But you're right that if you're looking for response rate as an endpoint, objective endpoint that you want to achieve in your patient, there's no doubt that this gives you a better response compared to the 52% that you would get just with chemo and the Herceptin only. Okay, so this patient went on FOLFOX and trastuzumab because she couldn't afford the immune checkpoint inhibitor. Of course, this is 2016 June, so we're just using this patient to illustrate a point. She did respond well, and then after about 8 months of maintenance trastuzumab, this patient got the disease back. You see that the ascites is again there. So that's after 9 months of maintenance trastuzumab. So what do we do next, Dr. Mansi? Biopsy to recheck HER2, paclitaxel, paclitaxel, what would you do?
Sir, so we have very good data. If she can use TDXD, then we would not do the biopsy because it has shown a response and good, PFS, even in those who have progressed on trastuzumab. But if she cannot afford it or it's not available, then probably I would try to use immune checkpoint for this patient since her CPS was quite high.
You would use second line immune checkpoint inhibitor for this patient. Okay.
Yes.
Viraj?
So biopsy, if HER2 is positive and PDX can be, we can get it, then and HER2, and then keep IO for third line.
Keep IO for third line. So you want to rebiopsy and then use TDX.
If HER2 is still overexpressed.
Okay, if HER2 is not overexpressed, would you use immune checkpoint inhibitor in the second line with a CPS of 25? Okay, nobody goes for paclitaxel.
So I think with such a high CPS, there's more confidence in giving a immune checkpoint. Right. If the patient is not going to go for TDX2, I doubt if I'm really going to do a biopsy because TDM doesn't really work very well in this situation.
Right.
I might directly go for an immune checkpoint inhibitor.
Okay.
So one question. So would people not use TDX if HER2 is not expressed? Because in the trial...
Very nice. Nice question. So Chintan, would you want to take that question? So Dr. Mansi is saying, yeah.
So the trial, it was irrespective of the HER2 testing, but HER2 ideally has to be tested to see whether HER2 expression is still there or not before going for TDX.
Okay. But did the Destiny Gastric do that, Chintan?
No, sir. It was not so.
Okay, so the Destiny Gastric didn't do it, but we would still, Amit, you would biopsy and then use TDX if you wanted to, or straight away go to TDX?
I don't know the answer to this question. When the TDX will come, we will think
when TDX comes,
it's all mental thought process. But can you go back to the previous slide?
Yes.
I can't answer the TDX. There is no data of
we'll remove that choice for you.
Line. Yeah, but there is no data of second line IO in a HER2 positive second line data set. I am not aware of any trial in HER2 positive. I think that's keynote 59, 60s and 61. Which one that second line was vis-a-vis paclitaxel. It failed, but that was HER2 negative. You are kind of applying to it. Fine. I don't know, why did we go to a second line? Which data set are we kind of talking about?
I think that's what you're referring to. The one that you're referring to, Amit, the subset analysis showing that if you had a CPS of more than 20, then you probably did better than paclitaxel. But that's a very small population. So it depends upon whether you want to use...
Were they HER2 positive?
I don't think being positive was an exclusion criteria because I don't know.
They were non-HER2 expressors.
But it was second line. Why would they have chosen HER2 based on, a patient based on HER2? It doesn't, sound very logical for me, because if you were doing something with HER2, you would do that in the first line, isn't it? Anyway, never mind. So you have a point there. That's based on a very small subset of patients who had a CPS of more than 20. So I don't know how much money you can put on that with a small subset. randomized to single agent paclitaxel. Okay, so
Just
since
one
there is
point,
a
one point.
Yeah, Viraj.
That we have data for Enhertu in CRC, Destiny CRC, where they showed IHC 1 and 2 had 0.
Absolutely, that's a good point.
I
But
would
you know,
definitely
interestingly,
want
the
I-
Destiny, I think Dr. Mansi is correct that based on the Destiny gastric, you don't have to do a biopsy because archival tissue was all that was required. But they did do a biopsy if your tumor was accessible, you know, especially if the stomach tumor was still intact, and nearly 60-70% of patients, okay, I put the numbers there, 20% had a gastrectomy and relapse. So at least a significant proportion had a tumor that could be biopsied. But HER2 negativity in that biopsy was not an exclusion criteria. At least the protocol does not mention that. This was more for biomarker analysis to study mechanisms of resistance. They did a biopsy before and then they did a biopsy afterwards when they progressed and so on and so forth. So Dr. Mansi is actually right that if you want to use TDX, you don't have to do a biopsy. You can straight away go and use the drug. But, you know, Viraj also has a point saying that it didn't work well in the 1+2+ colon. It worked well in the 1+2+ breast. So you've got the data all over the place. So sticking to data, it's okay to use TDX in a patient like this. So that's fine. So if you didn't have TDX, then I think, you know, the standard choice would have been paclitaxel and Cyramza. But, you know, everybody who wants to use an immune checkpoint inhibitor, you know, nothing prevents you from using it, especially if the CPS is 20% or more, 20 or more, and your patient has a deep pocket. So this patient went on just weekly paclitaxel. We said that, you know, patient can't afford. There was some response, of course, as expected for a short period of time, and then pack up as always. Fine. I think we will stop there. Are there any points that any one of the panelists wants to make or say anything before I hand it back to Viraj?